Hello students, and welcome to Pharmacology Introduction and Overview. So what is pharmacology? It's derived from the Greek prefix pharmako, and pharmako means drug or medicine, and the Greek suffix ology means study of. So we will be studying drugs or medicine during this course. Pharmacology actually began when human beings noticed that when they ingested certain plants, it altered their body functions or awareness. And from this humble beginning, a huge industrial and academic community concerned with the study and development of drugs evolved. So what are drugs? So drugs are nothing more than chemicals, right? So we'll talk a lot about chemistry in this class, because drugs are these chemical substances and they're used in both animals and humans in the diagnosis, treatment, and prevention of disease or other abnormal conditions, and also the prevention of pregnancy. Drugs include synthetically derived compounds, vitamins and minerals, and herbal supplements. So some of the divisions of pharmacology include pharmacokinetics, which is the study of what the body does to the drug as it moves through the body. So what this means is when you ingest a drug, you take an aspirin, you have a headache, so you take the aspirin, you swallow it, and pharmacokinetics studies what the body actually does to the drug, use it, metabolize it, get rid of it. And this process, this pharmacokinetics, is known by ADME. And ADME means absorption, which is absorption into the bloodstream, distribution, which means carrying the drug through the bloodstream and plasma to its site of action, metabolism, when the body is done with the drug and it starts to convert it to a metabolite that can be excreted by the body, and that's what the E is for excretion. How do we get rid of it? Pharmacodynamics is the mechanism of drug actions in living tissue. So whereas pharmacokinetics is what the body is doing to the drug, pharmacodynamics is what the drug is doing to the body. And what that means is, so you took that aspirin, right? Well, did you take it because you were in a little bit of pain, you had a headache? Well, that's the mechanism of the drug action. That's the pharmacodynamics, pain prevention, getting rid of a fever, making your platelets more slippery so you don't get a blood clot. These are all the pharmacodynamics involved in aspirin. Pharmacotherapeutics is the use of drugs to prevent and treat diseases, high blood pressure, high cholesterol. So that's pharmacotherapeutics. Another division of pharmacology, which I did not list here, is something called pharmacogenetics. This is pretty exciting. I don't know if I'll see it in my lifetime, but maybe in your lifetime, they'll be actually able at some point to draw your blood and let you know, oh, this medication is not going to work with you because of some kind of genetic profile that you have. So that's pretty interesting. If you ever have had like a bad reaction to a drug, an allergy or intense vomiting, diarrhea, nausea, something that happens when you've taken a drug, someday they actually may be able to predict that that will happen to you, and they'll give you a different drug. So what are some sources of drugs? So we can get drugs from a lot of different things, right? We can get drugs from the poppy plant. There's lots of, like, aspirin used to come from the willow tree, from chewing on the bark of the willow tree. Some minerals, things like magnesium. So if you've ever taken a Tums or a Rolate for stomach upset, usually that has some magnesium in it. Animals, we used to get insulin from pigs, porcine insulin. Now it's insulin is synthetic, it's made in the laboratory. And in fact, most drugs that we take today are synthetic kinds of drugs that are made in labs. So, what is our role as a dental hygienist in pharmacology? So, it's important that we know about specific drugs and our supplements and their interactions with the body and one another. You don't want to prescribe or tell a patient, oh, hey, you should take an aspirin for this pain after I've done a scaling on your teeth if they're taking certain medications because they can have a deadly reaction. So it's imperative that we all remain safe and provide safe and effective dental care. And knowledge of drugs can help to prevent as well as handle emergency situations. If someone becomes allergic to something, it's important to know what kind of drugs we would use to help that emergency situation and or reverse it if they have an allergy. So obtainment of an accurate and in-depth health history is important because patients can be taking a number of medications, both prescription and non-prescription. So that's important. You ask them all the supplements that they're taking because they don't count those as drugs. These may adversely affect their oral health. So some patients may be taking a calcium channel blocker for high blood pressure. And so they may experience xerostomia. So they have a dry mouth, they are at risk or an increased risk for caries formation. Right, so the dental hygienist's ability to recognize and discuss prescription and non-prescription drugs and supplements is an important role in patient education. So if a drug is going to cause them to bleed more when they're brushing their teeth and when they're having a cleaning, it's going to dry out their mouth, give them xerostomia. If they're taking a drug that, it's important that they come in first thing in the morning. So there's a lot of different reasons why we need to know about drugs. And the other thing is it's for yourself. What kind of drugs do you want to take? Do you want to recommend to your family members if they say, they have a headache or they just got a new prescription? You might be the only healthcare provider in the family and they may ask you what your thoughts are on different drugs that they're taking. And the other thing that you can do if someone asks you, and something that's available to you, is all the different resources that we have available. The Mosby's Dental Drug Reference, the DDR, we have a ton of those in the clinic. We have from several years because drugs are changing, they're being taken off the market, they're being put back on the market, they're used for different indications. So it's changing all the time. So it's important you have an up-to-date source of information. Another great source of information is the internet. You may look up a drug and it's, in your book and it's not there. It's brand new. So that's when you're going to call up the internet on your computer chair side, right with the patient there, looking at it together. And you might be able to tell them information that they didn't know about the drugs that they're taking every day. So how are drugs named? So you've probably gone into, the CVS or Walgreens, whatever, and said, oh, this ibuprofen is much cheaper than this Motrin, this Advil. So, what's the difference between them? Can you take the generic? So drug names themselves, first, it's known by a chemical name. And drug companies refer to a drug by its chemical name determined by its chemical structure. Sometimes it's also named by a code name. So for our purposes, you will never have to know the different names of drugs by their chemical name because they're really, really complicated. And I'll show you what one of those looks like in a moment. So a trade name is a name used for marketing purposes. So an example of the trade name is Motrin. And a trade name, the first letter is always capitalized. So you can see here Motrin and Advil are both capitalized. These are both trade names. So a drug company is the first one to discover this drug. So they would name it this chemical compound, and then it would be known by the generic name. That's the official name. Every drug has only one generic name. And so let's take, for example, ibuprofen. And I'm going to just pull it out of the head. Let's say Eli Lilly discovered ibuprofen. They would have the rights to ibuprofen. They would market it under the trade name Motrin for a certain amount of years. And in the book, you can read anywhere between 17 to 20 years under a patent. Problem with that is the patent, sometimes there's still working on the drug before it gets released. So sometimes it can be 17 years, sometimes it can be 20 years. The timeline starts as soon as they go for the patent. So it's a several years that the drug company like Eli Lilly paid to, formulate the drug and run the clinical trials of the drug. So then they have a certain number of years where they can sell the drug, and let's say they're selling it under the trade name Motrin. So no other companies at that point can make it. So then the patent runs out, other companies can begin to make the drug, and then they sell it under their own trade name. So ibuprofen, you may see it as Motrin, the original discoverer, or it can also be sold as Advil. And there may be companies that are just making the generic and just selling it under ibuprofen, which is usually cheaper. So let's take a look at this next drug. So this is all the same drug. So this is a drug you may or may not have heard of. This is Valium. So this is a benzodiazepine. It's a relaxer, relaxant. It's anti-anxiety medication. So its generic name is diazepam. Its chemical name is this big long string. It has 7-chloro, 1,3-dihydro, 1-methyl ring, 1-phenyl ring. So you won't be responsible for that. And then its trade name is Valium. And then another company, after the patent ran out, started to market and create their own drug, and they've called it Diastat. So this is all the same drug. So when that original company that, let's go back to ibuprofen, discovered that this drug they thought could do great with pain reduction, fever relief, they need to run phases of clinical studies. So these are expensive, and that's why originally that company is given rights to market the drug. They're the sole one that can market the drug and sell the drug to make back the money, especially for running these clinical studies. So there's 4 different phases. In each phase, they include more and more people. So phase 1 is to determine safety. Small and then increasing doses are administered to human volunteers. The biological effect of the drug, metabolism, and safe dose range are noted. Any toxicity is also noted. The main purpose of phase 2 is to test the effectiveness. And then any adverse reactions at this point are reported to the FDA. So an adverse reaction that may be reported to the FDA is suicidal ideation. So if a drug has someone have ideas that they may want to kill themselves, usually that drug through the FDA is going to be given a black box warning. And this could happen throughout any of the phases of the clinical studies if an adverse reaction is deemed significant enough. So a black box notation from the FDA means that the drug has exceptionally dangerous side effects. During phase 3 of the clinical studies, a larger number of patients who have the condition for which the drug is indicated are evaluated, and safety and drug efficacy. So the drug is deemed to be reasonably safe and it works. That's its efficacy. It must be demonstrated. And drug dosage is also determined during phase 3. And then clinical studies still continue after the drug is marketed. So phase 4 is post-marketing surveillance. So now it's out to the general population. And a lot of times this is when drugs will be removed from the market. They're going across large swaths of the population, this drug. They determine that there's a serious toxicity for some reason. Numbers of people have attempted suicide while taking this drug. And so they continue to monitor these events and reactions that happen after the drug has been released to the general population. So who's the they? Who is looking, who is regulating all these drugs? And what are the drug laws that exist in the United States? So the Food and Drug Administration, the FDA, So before this drug can be sold in the United States, it has to be determined that it's safe, it doesn't hurt people, and that it's effective. It does what it's supposed to do. So the FDA is the United States agency that grants approval for drug use. It also sets the standards for quality control in drug manufacturing plants. It determines if a drug should be prescription or over the counter. And, over the last 20 years, drugs that used to be that you have to go to your doctor to get a prescription, they've now made them over the counter. So that's pretty good. Like a drug, for example, um, like yeast infection medications, Monistat, and things like that, you can just pick up in the supermarket or at the convenience store instead of having to go to the doctor. They also regulate labeling and advertising of prescription drugs. They perform inspections, so they actually travel the world. The FDA has inspectors because a lot of our drugs are made in India and China. They're made actually all around the world. There's also drug manufacturing in Spain, Canada. So the FDA, any of these drugs that are going to be sold in the United States, and it's not even just human drugs, it's also animal drugs that they're looking at. So for your pets, they go to these different plants, drug manufacturing facilities, to make sure that they are clean and have strict quality control standards. The other thing the FDA does is it quantifies or it assigns a pregnancy category, it's called, to drugs. So a drug A, if it has a pregnancy category A, it means it's reasonably safe when a woman is expecting a baby. And then it goes B, C, D, and X. So an X pregnancy category would indicate that the drug has serious side effects to the fetus if a woman takes that drug while pregnant. So the FTC, the Federal Trade Commission, so what you probably know about the FTC is they don't let people put on food, drugs, and cosmetics, like that natural or organic without actually being organic. So it bans like misleading advertising of food, drugs, and cosmetics. OBRA, the Omnibus Budget Reconciliation Act. So this is a law, and this requires all pharmacists to offer counseling concerning medications delivered to Medicaid patients. But essentially, it is the State Board of Pharmacies are requiring counseling to be offered to all patients. So the last time you went to pick up a prescription, they probably said, do you have any questions? Okay, if you don't, please sign here. So that's what it has to do, that they offer any advice if you need any advice for the drugs that you're taking. So the Harrison Narcotic Act, so in 1914, so before the Harrison Narcotic Act, so before 1914, over 100 years ago, mixture sold over the counter could contain things like opium and cocaine. And these mixtures were promoted to be effective for many problems. If your baby was crying a lot or you were very nervous, weight loss, things like that. But they would have these very, very powerful, very addictive drugs in them. So the Harrison Narcotic Act and its amendment provide federal government control over narcotic drugs and require registration of all practitioners prescribing these narcotics. So in 1914, it established regulations governing the use of opium, opiates, drugs like opium, and cocaine. And in 1937, some marijuana laws were added. So Mrs. Winslow's soothing syrup, so look at here, this is the mother's friend for children teething, right? I just want to give my babies this soothing syrup. So what was in this soothing syrup? So it was morphine. And so that would probably really soothe the children. They would probably stop crying and be very quiet. So that's probably why it was the mother's friend. So this would be pre-Harrison Narcotic Act when this concoction was sold over the counter. So the Drug Enforcement Agency, the DEA, is part of our Department of Justice. So its purpose is to regulate the manufacturing and distribution of substances that have a potential for abuse. The Controlled Substances Act of 1970, so we just talked about the Harrison Narcotic Act, which started to regulate the use of opium, opiates, and cocaine. The Controlled Substances Act of 1970 replaced the Harrison Narcotic Act and the Drug Abuse Control Amendments to the Food and Drug and Cosmetic Act. It sets current requirements for writing prescriptions. So prescribers of drugs that have the potential for abuse have an assigned DEA number if they need to write prescriptions for controlled substances. So the DEA also enforces the Controlled Substances Act. And what the Controlled Substances Act is it creates schedules for drugs that have shown the potential for abuse. And the lower the schedule number, Schedule 1, the highest the abuse potential. So Schedule 1 would be highest abuse. There is no known recommended purpose why someone would need heroin, right? Heroin, there's no prescription potential. There's no one that is going to take that. It's very addictive. It has a high addictive potential. So a Schedule 1 drug has no indications for any kind of drug therapy. Now, the Schedule 1 drug federally still at this time is marijuana. So we'll talk a little bit more about marijuana in a couple of weeks, about state laws, federal laws, how federal trumps the state laws. So we'll spend some time talking about that in a couple of weeks. Schedule 2, things like morphine, amphetamines. So I say amphetamines, why would we need that, right? Because a Schedule 2 drug has a high abuse potential. However, there are clinical indications for these drugs. So some amphetamine salts, things like Ritalin, are used for persons with ADD or ADHD. Morphine is used for patients in a lot of pain at the end stages of cancer. Schedule 3, we have Tylenol 3, which is Tylenol with codeine, hydrocodone, Vicodin. So some of these drugs actually used to be in Schedule 4, but they were moved up to 3 because with the heroin opioid crisis, these drugs have been shown to be, again, highly addictive, high potential for abuse. So the DEA monitors prescribers that are writing these controlled drugs. So an oral surgeon has a specific, oral surgeon A has a specific DEA number. An oral surgeon will need to probably prescribe a lot of Tylenol with codeine or Vicodin prescriptions. So the DEA, I have no idea what the number is, probably has some number that this person works this amount of hours, they should write about this amount of prescriptions per year. If you go over that amount as a prescriber, then the DEA is going to visit your office. A lot of agents will come, armed agents will come to your office to figure out why you are writing over the number that they deem appropriate. So an oral surgeon has a certain threshold that they can write, and like an orthodontist, right? An orthodontist probably shouldn't be writing a lot of prescriptions for OxyContin. So different specialties will have a different threshold, and the DEA regulates how many prescriptions these prescribers are using and prescribing. So what are the requirements? So, if you're a prescriber and you want to prescribe a Schedule 4 drug, the requirements are different than if you want to do a Schedule 2 drug. So if you are a prescriber, your DEA number is required on the prescription. So Schedule 2 through Schedule 4 drugs require a prescription. Schedule 2 drugs must be typed or written in pen. They cannot be telephoned to the pharmacist and require a new written prescription for refill. So if someone out there is taking like an amphetamine salt for ADD, they are probably familiar with they have to go to get a new written prescription for every refill. Schedule 3 through 4 drugs may be phoned to the pharmacy, but may not be refilled more than 5 times in a 6-month period. Also, some states require triplicate or duplicate prescription blanks for Schedule 2 drugs. So what's a prescription? So a prescription is a prescriber's orders to a pharmacist to dispense a specific drug to a patient. So healthcare providers who can write prescriptions include physicians, veterinarians, dentists, optometrists. And in certain states and under certain guidelines, physician's assistants, nurse practitioners, pharmacists, and dental hygienists may also write prescriptions. So currently they use the metric system. So you've probably heard of milligrams or milliliters or things like that. That's our metric system. The apothecary system was the previous system. Never seen this in all my years. It's very, very old. It includes things like drams and grains. So very like an old style way. I think probably the metric system is used, I would hazard a guess, at almost 100% of the time. So what are our best prescription writing practices, right? Use the correct format, write it carefully, keep a copy in the patient's chart, avoid Latin abbreviations. So three abbreviations in Latin: QD means every day, QOD means every other day, and QID means 4 times a day. And those can look pretty similar on a prescription. So choosing the wrong one could have disastrous results. Um, Keep the prescription blanks in a secure place because there will be patients that want to get a hold of your prescription pad. Don't write the DEA number on a prescription that is not a controlled substance. So dentists prescribe things like amoxicillin if a patient has an infection, and there's no reason to have a DEA number. Amoxicillin is not a drug that has an abuse potential. So that's kind of important to kind of differentiate. So you need a prescription for amoxicillin. That's through the FDA, the Food and Drug Administration. But you also need a DEA number. So let me think. Let me get an example here. All right. So a drug like, let's say, amoxicillin. So amoxicillin is a drug that has no abuse potential, but the FDA has deemed you need a prescription, right? So that drug is under all the control of the FDA. Now let's take another drug. Let's take a drug like cocaine. So for cocaine, that's actually a Schedule 2 drug because cocaine actually is a powerful topical numbing agent. They still use it in nose surgeries and throat surgeries to numb areas. Sometimes when they stick a tube up your nose, they may actually numb it with cocaine. So that's going to be sort of under the DEA, right? So the DEA, right? Nobody's going to give you a prescription for cocaine. But there are some that are kind of in the middle, right? They have some FDA regulation and some DEA regulation. And a drug like that might be Tylenol, FDA, with codeine, an abuse potential, DEA. So DEA numbers only go on prescriptions when the drug that they are recommending or prescribing, the dentist, has a potential for abuse. So let's talk about the metric system. Yay, so that's our primary system used in pharmacy. So solid drugs, right, like amoxicillin, let's say, for example, right, the person needs pre-medication, so they are going to need to take 2,000 milligrams, which is 2 grams of amoxicillin an hour prior. Liquid drugs go by volume or milliliters. So pills and milligrams, liquids and milliliters. The way I kind of think about it is, I get 2 liters of Coke or Pepsi, whatever you drink. And I always think liters, 2 liters, 2-liter bottle. So that's the liquid, right? And pills are always grams. So household measures. So, if the doctor, wrote on the prescription pad, this person should take 5 milliliters of whatever the drug is every 4 hours. So if the pharmacist didn't transpose that 5 milliliters, most people don't know what 5 milliliters means in the household system. So the pharmacist will transpose that direction, that 5 milliliters, to the household system for the patient to read, and it's 1 teaspoon. So 5 milliliters equals 5 actually cc's or cubic centimeters. You might have heard of cc's before, which equals 1 teaspoon. So that's the household measurement. Having a little drink here of some iced coffee. So I'm doing this. So what's the prescription look like? So most of us actually don't even get the written prescriptions anymore, the paper prescriptions. So many of them just go right through the computer. But if you looked at a paper prescription, there'd be a header or heading, and it would have the prescriber and the patient's name, address, telephone number, and the date. The date's important. People shouldn't be trying to fill prescriptions from 2 years ago for pain, for prescriptions for pain. The body, or like the meat of the prescription, you'll see the RX symbol, and RX actually means take thou. The name of the drug, the dosage size, so number of milligrams or concentration, milligrams per milliliter, the amount to be dispensed, and usually you'll see either DISP or the hashtag or number sign, and directions to the patient preceded by SIG. So it will say SIG, and those are the directions to the patient. And in the closing, the prescriber signature, the DEA number if it's a controlled substance, and refill instructions. So now you've gone to the pharmacy, you've picked up your prescription, or better yet, it was mailed to you, and your doorbell rings, you answer your door, and your drug is there. So what is happening? What is the drug action and the body's handling of the drugs? So we're going to do a lot of terminology. So most of it is pretty, like if you think about it, it makes sense. So onset of action. Time interval between administration and therapeutic effect. I have a headache, I swallowed the pill, and usually about 20 minutes later, my headache is gone. So the onset of action of something like ibuprofen is usually about 20 minutes. The site of action, where the drug exerts an effect. So my headache drug, you might think, oh, it's going into the brain. It actually doesn't work in the brain. It works out in the periphery, actually getting rid of something called prostaglandins. It prevents prostaglandins, which makes our body sensitized to pain. So the site of action for something like ibuprofen would be in the peripheral nervous system. The mechanism of action, how the drug works. So again, we'll stick with ibuprofen. Hey, how does that work? It inhibits or stops prostaglandin synthesis. The dose, how much do I need to have an effect? So if we're still talking about ibuprofen, each pill is usually about 200 milligrams. So when I have a headache, I'll usually take 2 ibuprofen, so about 400 milligrams is the amount. And then the duration of action, how long the drug produces the effect. So usually ibuprofen will work, let's say it's not a head pain, let's say I have a knee pain. So usually my dose would be a little higher of the drug when you have like, I don't know, I fell and I hurt my knee. And the length of time that the drug usually works is probably about 6 to 8 hours for something like ibuprofen for knee pain. So here I am, I've got my pain, I fell down, I hurt my knee. Well, how is this ibuprofen going to work? So for it to work, I got to somehow get it from the outside on the counter inside to me for it to work. So there's many, many ways it can work. Oral, rectal, injection, inhalation, and topical. So the route of administration affects the rate of onset, the rate of absorption. And when I talk about the rate of absorption, I'm talking about how quickly it is absorbed into the bloodstream and the duration of action, how long it's going to work. Because of course, if you absorb a lot more into the bloodstream, it's going to work longer because you actually have more drug available to continue the action. So if you think about something like, I don't want to compare ibuprofen again, but if you take a drug orally by mouth, it takes quite a bit longer to reach your bloodstream than if I put it in a bag in an IV and put it straight into your bloodstream, right? 100% is absorbed when you do an IV versus oral, much fewer molecules are absorbed into the bloodstream. So, also with administration, there are 2 ways, the enteral and the parenteral. So the enteral administration is through way of the GI tract. So if you think about your body, think about your mouth to your butt, right? To your anus is one long tube. And this tube is your enteral tube, the delivery of the drug orally or rectally on either end of that tube. Parenteral is all other means of delivery, all other means outside of your mouth butt tube. But usually parenteral is thought of as an injection, but inhalation is also a parenteral route because it goes to the lungs. It's not going down the tube to your GI tract. So PO is a Latin abbreviation for by mouth. So the enteral route by mouth is, hey, it's pretty good, right? It's safe, it's convenient, it's cheap. So some of the disadvantages are stomach acid and enzymes, things like that. That's why you can't swallow insulin, right? Insulin will be degraded by your stomach acid and your enzymes in your stomach, and you have no insulin that will work for you. You can't swallow it. There's no such thing as oral insulin. It's a slower onset because it has to go through it's something called the hepatic portal system first. Once it reaches your stomach, it will actually cycle through your liver before it's spit out into the bloodstream. So when you swallow something and it goes to your stomach, you swallow a drug, before it gets to your bloodstream, because the body is always trying to keep you safe, first we'll pass through the liver for, just figuring it out, seeing what's going on with it before it actually allows it into your bloodstream. So when it does that, when it goes to the liver first, and you want to think of the liver as the site where drugs are metabolized, packaged up, getting ready to be removed. So when you swallow a drug and it goes through your stomach and then it goes through your liver, a certain portion of the drug will be metabolized into an inactive form before it gets to the bloodstream. And this is called the first pass effect. right? So let's see what I wrote here. The metabolism of a drug and its passage from the liver into the circulation. So a drug given by the mouth may be extensively metabolized by the liver before reaching the bloodstream. And this is considered a high first pass effect. This same drug, if it's given intravenously, IV, it bypasses the liver that first pass, preventing the first pass effect from taking place. More drug reaches the circulation. So of course, all of our bloodstream is sort of a closed tube of vessels. Eventually, all drugs will go through the liver, but by preventing it from going first, you get that first burst of active molecules in your bloodstream. So some drugs with a high first pass effect will almost be rendered completely inactive if you swallow them. So again, another Latin abbreviation, enteral route PR by rectum. So what are the advantages of this? So if you're throwing your guts up, sometimes they will give you a nice suppository with drugs in it that will prevent you from throwing up. Infants, children, elderly also will get things rectally. Unfortunately, the amount of drug delivered or that actually ends up entering the circulation is unpredictable, and for the most part, patients really don't like having suppositories placed rectally. So those were our enteral routes, mouth, rectum. Now we have parenteral around the enteral system. So we have IV, IM, sub-Q. IV, rapid and predictable. No first pass effect, good. Allergic effects can be profound. So that is a con. So let's say I take my amoxicillin and swallow it. Let me have some coffee first, wait a minute. So I've swallowed my amoxicillin. Uh-oh, starting to get some hives. Uh-oh, I'm starting to get an allergy to this. What's happening? What can I do? Well, they might tell you to take something called syrup of ipecac, right? Or you stick your fingers down your throat. They make you throw it all up. You're having this profound allergic reaction from something you've taken by mouth. How do we get rid of it? We make you throw it up. Let's say you go to the hospital. They're like, oh, they need amoxicillin through an IV. They pump it. You start with your allergic reaction. There's no way to suck it back out of your bloodstream. Now they are just needing to deal with the profound allergic reaction. And that's a big con to an IV drug, right? You can't easily get it out. Intramuscular, so hepatitis B, that's pretty good absorption there. So for a long time, our hepatitis B vaccinations were put into our bum, but then our bums got too fat, right? We have too much fat layer on the bum. Intramuscular injection, things like hepatitis B vaccine, needs to reach the muscle. If it doesn't reach the muscle, it gets trapped in the fat. It's not going to work. So now they put it, what do they put in our deltoid? Oh, that hurts so much, right? So that's intramuscular. Sub-Q is just under the skin. This will absolutely be on one of your board examinations. What kind of injection is a local anesthesia injection? In some books, it calls it an intradermal, which I'll talk about, but the answer that they're looking for is subcutaneous or sub-Q. And you can see here how the different injections look. Look at how long that has to be, right? So we have to get through that fatty layer under into the muscle for the intramuscular. IV's going right here. That vessel, subcutaneous right underneath the skin. So intradermal, so that's within the skin between the epithelium and the underlying connective tissue. So when you went and had the TB test, you were looking on your forearm. Oh, is it bulging when they go and measure it? So that's an intradermal injection. Intrathecal is into the spinal columns, if anyone here has had spinal anesthesia. So topical, so through the skin, so things like nicotine patches, fentanyl patches for pain. All these things are impregnated into patches, and then they are placed on your skin and absorbed. Mucosal, so that's things like topical anesthetic prior to an injection. Also sublingually, things like nitroglycerin that are placed underneath the tongue. So the skin underneath the tongue is so thin that the uptake from something like nitroglycerin, it can actually approach IV. The big thing with that though is you need saliva. If the person's mouth is as dry as the desert, it doesn't dissolve, there's no uptake. All right, so someone has to be pretty juicy to dissolve something sublingually. And then we also have subgingival, and that is things like Arrestin and Orachix, which is like a numbing agent. And then lastly, but not leastly, which is not a word, inhalation. So things like nitrous, bronchodilators, asthma, right? You breathe the gaseous drugs into your lungs, taken into the blood through the very, very thin alveoli, and onset of action is very quick. And think general anesthesia, all those different drugs. So that is it for this lecture.